The broadcast is now starting. All attendees are in listen-only mode.
Good evening, and thank you for joining SpectraCell's Thursday night webinar program. My name is Heather Vorse, and I will be your host for this evening's presentation. Today's topic, pregnancy and infertility, will be very useful in helping understanding our test. Before we begin, I have a few quick announcements. All callers are placed in lecture mode to avoid interruptions during our presentation. To submit a question, please click on the Question tab. At the end of our presentation, Dr. Grabowski will address as many questions as time allows. The presentation is being recorded and will be available on our website at www.spectracell.com in our Clinical Education Center. The slides will also be available on the site for download, and you will automatically receive a link to access this presentation once it has been posted to the website. Once again, we are pleased to welcome back Dr. Ron Grabowski. Good evening.
Good evening. Thank you, Heather. Good evening, viewers. I'm very excited about this particular topic because this is a topic that I see very often in my practice. And the one thing that I find very interesting with this particular topic is it is usually the female patient that approaches the office first and talks about her issues with infertility. And one of the first questions I ask her is, where is your husband? Where is the one that is also involved in this particular pregnancy or chance of having children? And of course, one of the common statements that the woman says is, well, my husband says that he's fine. And I always kind of chuckle at that because one thing that I find often in my practice is that the male patient has as many issues or more issues as the female patient. And so one thing that you're going to see tonight is that we're going to cover a lot of topics involving possibility of issues involving the male individual. However, we will also talk about female issues and a lot of issues that have been lectured about in the past with experts on infertility and nutrition is, of course, certain deficiencies with the female. And like I said, even though we will discuss those, we're going to concentrate a lot on the male individual and intermingle the two as far as the deficiencies and how it may affect the female as well as the male. The one thing that I think is really alarming to me is the statistics on infertility. And you can see here with the second bullet that the World Health Organization, what they define as far as infertility, but also in the bullet below that where 1 out of 6 couples during the time is common finding of infertility. And then you see that approximately 10 to 15% of couples, once again, have infertility, and roughly 50% of those involve the male individual. So this is why I think it's very important that we always include both individuals on our initial consult. And we show them that it can be, once again, one of the individuals that's having a issue that could be concerning the infertility problem, or it could be both. And the other thing that's very important is once you start to address these nutrition issues, that you give them a time frame. Because a lot of people, once again, think that, okay, I'm deficient in vitamin E, I can take vitamin E for a couple of weeks. Can we start trying to have children again? Or if they're getting ready for in vitro fertilization, how long should I supplement prior to this particular process? So those are some of the issues that we're going to discuss tonight. And once again, we're going to discuss on the diagnostic tools that should be used when we are evaluating that. I think you're going to find that a lot of nutrients that we're going to talk about tonight may not be the nutrients that you would associate with infertility, and that's one of the reasons why I picked it. A lot of us are aware of the, of course, folic acid deficiency and iron deficiency, and even though I'm going to speak about those, I picked some other nutrients that I see often deficient on individuals that come into my office for infertility issues and how they are related and how it's been documented in the scientific research on the effect that they will have on the individual. So I think that's something that definitely has to be understood. Now, of course, as we talk about the male versus female, there are certain nutrients that are going to be more commonly deficient in the male versus the female and vice versa. And there are certain things that the male may be doing in regards to dietary habits or the physical makeup being more muscular than the female that may have also a major issue. And generally speaking, most male individuals will consume more of the meat and potato type situation, where the female is going to go more towards the fruits and the vegetables, which of course considers different deficiencies when we are looking at the individual from a nutritional evaluation. As you can see here, the failure, whether it's production or the motility of the sperm, has been highly indicated in male infertility. And we're going to talk about some genetic abnormalities later in the show. And we all know that there's always a genetic makeup that's going to affect us, whether you're male or female. But how do we get around those particular genetic defects or abnormalities? And of course, the most common one that people talk about is the MTHFR. And even though we will talk about that in this program tonight, I think you're going to find that there's other genetic makeups or SNPs that we have to consider with these individuals. Now, one of the things that I find very interesting, and you probably see the same thing in your office, is when couples talk about in vitro fertilization. And what's interesting to me is how they think that because they're going through this process, that they're automatically going to have a child. That it's like, okay, this is a process, we're going to fertilize the egg, and of course it's going to be 100% chance of pregnancy. Now, of course, the infertility specialist is going to correlate this and also inform them that that's not the case. But if they get to an individual that is dealing with nutritional intervention, and once again, they haven't looked at some of these statistics that are in front of you right now, you can see that there's a difference, of course, between pregnancy rates with IVF and live birth rates. And as we all know, that as we get up in age, that the percentages decrease. And we all have heard about getting to the point of 40 years of age and above. And what's important is, why are these statistics so low, and why do they change as we get up from a 35-year age group to a 40 and above? And once again, I think we have to highly consider the nutritional aspect. And one of the things that I can tell you dealing with OBGYNs that specialize in IVF is the ones that really implement nutrition and evaluate nutrition have much better understanding and percentage rates of success. And it makes a lot of sense because, of course, in order for cells to divide, in order for cells to survive through certain aspects, we have to, once again, have that. We have to have the adequate nutrition. And I always tell couples when they come to my office is the time, the several months before the pregnancy is just more important than during pregnancy. And that's something that we really have to emphasize to our patients, is planned pregnancies, get the mother healthy, get the father healthy, and then, of course, continue to work on that throughout the pregnancy. So you can see here, once again, the percentages of IVF procedures that result in pregnancy, and of course you can see the ones that result in live birth. So we have about a 7% decrease here that shows that. And then you can see the various other percentages that you can refer to in the future. But one of the things that's really important is that if you look at the second to bottom bullet where it says the report notes that 1 in 10 U.S. women of reproductive age has consulted a doctor for infertility issues. Now, once again, this is women. And the question is, it should be couples, okay? That couples should, of course, consult a doctor, not just the woman. And in maybe some of these cases, of course, the couples did do this rather than just women. But the point is, it seems like a lot of the emphasis has been on the female patient rather than equally on both female and male. And that's something that I really want to emphasize with you tonight is that we need to involve both individuals from the very beginning to make sure that both of them are in optimal nutritional health in order to be successful with the pregnancy. I don't think we can go anywhere today and pick up a nutrition article or a journal that doesn't talk about oxidative stress. And we look at so many diseases today, whether it's diabetes, whether it's cardiovascular disease, whether it's autoimmune diseases, and we all go back to the point of oxidative stress. And that's why this slide is very early in the presentation. And you will see how I'm going to tie this slide into several nutrients tonight. And it's important that we do something with oxidative stress. And it's something I think that is highly overlooked. And people that look at nutrition and fertility, especially females, when they are given or provided with a prenatal vitamin, is looking at the antioxidants in that prenatal. A lot of times they are very low. For example, the vitamin E might be 30 international units, or the vitamin C might be 60 milligrams. And we're finding out that those dosages, even though they are so-called 100% of the RDA, may not be adequate for protecting the female against the oxidative stress and what may be affecting their ability to get pregnant. And so it's very important, and you will see this throughout the entire program this evening, that antioxidants are huge players in fertility and completing pregnancy. And I'm going to give you some information that's recently been published about some of the antioxidants like vitamin C and their big role in pregnancy as well as the process of getting pregnant. So once again, this is something that we have to keep in mind, and you can see whether it involves the ovaries and the egg production, and also you will see when it comes down to the sperm motility, sperm integrity, and what's going on here. So this slide, for the most part, has been more or less indicated from a female standpoint in how we have seen oxidative stress doing this. Now, on the other hand of talking about stress, I also am amazed on how many women have come into my practice and said, my OBGYN says, I just need to relax. I need to decrease my stress. And I always chuckle at that because it's easy to say that, but we know that psychological stress or physical stress can also cause nutritional deficiencies. And so not only do we have this oxidative stress, but now we have this psychological stress that may be affecting our nutritional status. And it may be affecting different nutrients that aren't antioxidants, but once again are vital for the fertility process. So let's talk now about antioxidants in the male infertility or male status. And you can see here that the actual sperm function is the most common cause of infertility. Until recently, it's really been difficult to evaluate and treat these individuals, but once again, we do know that. We also know that our fatty acid contents are a major player in the male patient. And so whenever we talk about fatty acids, we know that there's this process of lipid peroxidation that can occur. And we know we have to protect those particular structures, whether it's in cardiovascular disease or whether it's in male fertility reasons. Whatever the case is, every cell membrane has the ability to go through lipid peroxidation. And you can see here at the very bottom that there's numerous antioxidants that you're all familiar with that have been associated with treating infertility. And it's been primarily addressing the free radical / antioxidant balance. And I think that's very important. But the other point that I want to emphasize tonight is what's the dosage of each of these? How do we know that the dosage we're providing is actually adequate for that male individual or female individual? And I think that's the big key and the main point that I want to emphasize tonight is how are you measuring if someone is nutritionally adequate. Because we all know that there's no way that we can just look at an individual and say, oh yeah, you're deficient in vitamin C or you're deficient in vitamin E. Now we can speculate that some of these deficiencies may be there because of their dietary habits, because of their exercise regimen, because maybe of their previous or present pathologies that they may have. For example, if they're diabetic already and now they're trying to get pregnant, we can predict more or less some of these nutritional deficiencies that may be there. But the point is, none of us can determine that by just looking at them. And some of the standard tests that people are using, the complete blood count, the comprehensive metabolic profile, even the iron profiles, they will give us the recognition of anemia. But the question is, what about that microcytic hypochromic anemia that we all look at, or we've been all trained to look at, and everybody jumps on iron? Oh yeah, you're female, you have a microcytic hypochromic anemia, you must be iron deficient. And then we do an iron profile, we see a ferritin that's normal, and then where do you go? So I'm going to bring all of that forward and show you how certain deficiencies that we are aware of now that affect fertility reasons also may affect some of these general tests that we're using, but there's no way that you can determine that by just a simple CBC with differential. That you have to go deeper into diagnostics to say this is the nutrient that's causing that particular presentation on the CBC. And yet, it's very commonly looked at and said, okay, I'm just going to give you iron. Last year, I was talking to a large group in the East Coast, and some of the doctors in the group were, of course, OBGYNs, and this discussion came up. Because if you look at a CBC, you see a microcytic hypochromic, what would you give? And a lot of them, of course, indicated that they would give iron. And I said, there's no way you can just determine that by looking at the CBC. And then I correlated some of these particular deficiencies. So once again, I'm going to give that information to you this evening, and I want you to think about that the next time you order a CBC and you get a microcytic or macrocytic type anemia. So let's talk about CoQ10. One of the things, of course, we all know about CoQ10 is CoQ10 is something that we should consider in cardiovascular disease. And we all know that, and now there's research out, of course, CoQ10 in Parkinson's disease, and CoQ10 in ALS, and CoQ10 in Alzheimer's, and so we know there's also a neurological connection. Well, some people, maybe some of you or all of you have heard that CoQ10 deficiency has been associated with male infertility. And so this is something that we have to look at, and you will see in another slide how giving CoQ10 can affect another nutrient that actually can also affect fertility reasons. Now, here's a study, as you can see, that was published in Journal of Urology in 2012 involving a little over 200 men. And once again, they had unexplained, or if you want to say idiopathic, right, infertility, and they were split into groups. One of the big keys that you can see here is the dosage now. A lot of people will do 50 milligrams, some people will do 100 milligrams per day, but in this particular one, they gave 200 milligrams. And not only did they give CoQ10, but it was the type of CoQ10 that they gave. In this case, of course, they gave ubiquinol versus ubiquinone. And this is what I like to show to my patients, and hopefully you feel the same way, that, you know, there's scientific evidence out there indicating that not only a certain dosage has to be used, but also a certain form has been shown to be maybe more beneficial than others. But in this case, you can see that, once again, they relate it to the mitochondria of the sperm. And they indicate that, of course, we all know that CoQ10 is very important for ATP production. And if we don't have that adequate ATP production, that, once again, every cell in the body may suffer. And once again, in this case, they're talking about the sperm and, of course, the mitochondrial respiratory chain. So we mentioned earlier about lipid peroxidation. We know that, once again, not only is CoQ10 / ubiquinol going to help with this, as it states in the last bullet on this particular slide, but also in the energy production and the dosage. So if you have an individual, you test them for CoQ10, they come up low, they're having issues, of course, with fertility, is refer to this particular notation is it was 200 milligrams of ubiquinol that they used. You can see the time period was 26 weeks. And one thing that I want to emphasize with CoQ10 is usually we want at least a 4 to 5 month dosage period to correct a CoQ10 deficiency. So if a couple comes into your office, you do some diagnostics, the male comes back at CoQ10 deficient, they say, well, you know, we want to try to have children next month. Well, if they are CoQ10 deficient, you have to once again inform them that it's unlikely that they're going to be able to correct that within that month period, that they're going to have to go out about 4 months before they do it. Now, once again, they may be able to be successful with fertility, but I would once again highly recommend that you tell them wait at least 3 or 4 months. Now, it's a little different, and it's going to be a little pressure on you, especially if they say, well, we've been doing all these preparations for IVF, and you know, it's supposed to happen in 3 weeks, 4 weeks, 5 weeks, and they have a CoQ10 deficiency. So once again, take that into consideration. A nutrient that has received a lot of press over the years, once again, is vitamin E. And what's interesting about vitamin E is you can see here that where they've used tamoxifen in this particular study because of the estrogen blocking capability is that there is a relationship with vitamin E and improved sperm concentration. If you notice in here, they also talk about carnitine. And carnitine is something that we will talk about here in a minute. But the dosage, once again, you can see that they use vitamin E in 100 milligrams, which is almost equal to the same as 100 international units 3 times a day. And so once again, using the right dosage and the frequency and possibly associating with some other nutrients. But the point is that we know that vitamin E, being an antioxidant, protecting us against lipid peroxidation, is going to be very important. And this is something that we see. The same thing has to be applied to females, is we're going to have that possibility where the egg is not real healthy. It's going to go through lipid peroxidation, or has a capability of going through lipid peroxidation. So her antioxidant status is just going to be as important as his antioxidant status. And once again, just saying, oh, I'm going to give you 200, 400, 600 international units of vitamin E a day doesn't necessarily assure them of pregnancy or once again, a live birth. So it's important to do some diagnostics, and even throughout the pregnancy to follow up those diagnostics to see if that dosage is really adequate for the female. Once again, for the male, we're going to look at him prior to the whole process. Well, anytime we deal with vitamin E, we should always consider selenium. And any of you or all of you that have been practicing nutrition for several years know that there's certain combinations of nutrients that go with one another. We know calcium goes with magnesium. We know that zinc goes with copper. We know that selenium should go with vitamin E. We know that all the antioxidants should be in balance. The B vitamins, once again, should often go together because of the relationship with one another. So there's combinations that are very important. And you can see here that this is the same thing. This particular study had to do with sperm motility. So if you have a patient that comes in and he says, my sperm count was good, but my sperm motility was abnormal. Once again, do you just throw a multivitamin at this particular individual, or do you say, look, we need to find out specifically what you're deficient in to say, yes, we need to concentrate on selenium, we need to concentrate on vitamin E, or we need to do a combination of both of those. So it's very important that we isolate the specific nutrient or nutrients that may be deficient, and then giving them the proper dosage for a period of time. Now, as we all know, vitamin E toxicity is very rare in comparison to vitamin A toxicity. But at the same time, there can be imbalances that can occur. One thing I can tell you, and I see this a lot in my practice, is people that take a lot of omega-3 fatty acids. That I found that people that take large dosages of omega-3s have a tendency to go towards vitamin E deficiency. Now, it's a catch-22 when we're talking about pregnancy, because we know and that the omega-3s are very important for the neurological development of the fetus, and we want to make sure that the male as well as the female have adequate amounts. But at the same time, are they doing something prior to the pregnancy or causing some deficiencies because of the lipid peroxidation or the imbalances? So this is something to keep in mind, because omega-3 consumption is so high and frequent today in the United States that we need to make sure that someone taking a particular dosage hasn't caused a deficiency like vitamin E. You can see here that, once again, selenium has a separate role in regards to infertility, and there are certain forms or sources that we look at. The most common one that I recommend to my patients as far as selenium is concerned is the Brazil nuts. But you can see that there's other sources here that are discussed. Of course, most people, when we talk about the recommended daily allowance, as is shown here, this is something that has been developed several years ago, and I want you to remember that, because I think any of us that have been in practice for some time, if we look back at the recommendation for vitamin D back in 1989 to the present time, we can see that the recommendations today are much higher than they were back then. Back then they were 400 international units, maybe 800 maximum, but you didn't go above 800 international units for vitamin D. Today, people are taking 2,000, 4,000, 5,000 or higher. The same thing is true with selenium. It's been several years since the update, or we really reviewed and looked at selenium. So once again, how do we know that that particular individual has a selenium deficiency? One thing to keep in mind, selenium plays a major role in thyroid function. And so if a female comes into your practice and she has a history of thyroid dysfunction, this is a nutrient that is highly looked at. Once again, selenium, as you're aware of, is required to convert T4 to T3. So that's one issue. Another issue is, of course, if an individual has a history of following a gluten-free diet. We know that these individuals often have a tendency towards selenium deficiency as well. And so, once again, lifestyle considerations, previous pathologies such as thyroid dysfunction are all important. And then you can see the function of selenium. The main thing that we've seen here is the protection, is as an oxidative stress can increase in the body, is do we have enough antioxidants such as selenium that's going to help quench those free radicals? And you can see that they've shown that selenium can protect against the oxidative DNA damage in the sperm cells. And we know it also has been shown to affect the sperm motility. So now we're talking about the lifespan of the sperm and sperm motility. The other thing that has to be considered, like I said, is the balance between selenium and the vitamin E, but the overall antioxidants. And this is something that must be looked at. And I usually find that we can get up to around 200 micrograms a day to usually correct the individuals with selenium deficiency. As I mentioned earlier, that there's a study where they talked about vitamin E and carnitine. And carnitine, when we think about carnitine, for the most part, people associate this with possibly weight loss. They associate this with, of course, cardiovascular disease. We see that a lot in exercise, that people that are in intense exercise have definitely affected the carnitine levels. So let's take the male or the female, but in this case, the male individual with a heavy exercise program. There may be marathoners, they're triathletes, or they exercise 4 or 5 times a week, and they don't realize that they could be getting into a carnitine deficiency. The other thing that's important about this is the role of carnitine, or the association, I should say, of carnitine with CoQ10. That we have found that when people take CoQ10 supplementation, that we can actually cause a carnitine deficiency. And as you notice in the previous slides, we talked about 200 milligrams of CoQ10 in male individuals. Well, I have found in my practice that when an individual goes above 100 milligrams a day of CoQ10, that they're more likely, it doesn't happen all the time, but they're more likely to get carnitine deficiency. So once again, people come in, especially the male individual, he says, oh yeah, I read on the internet that CoQ10 is good for fertility, so I've been taking 300, 400 milligrams of CoQ10 for the last year. Well, that's great if they're CoQ10 deficient, or they were CoQ10 deficient, but now they may actually cause the carnitine deficiency. So this may now inhibit this individual from having a child. So once again, it's important that we get these relationships down and we correlate this. Now, as I mentioned, one of the things that often is talked about or emphasized in a prenatal vitamin or prenatal product, I should say, is folic acid, B12, and iron. And we know the main reason, of course, for the folic acid and B12, it's the DNA and RNA production. It's, of course, the neurological development of the child. And then, of course, when we look at iron, iron has numerous functions in the body. And one of them, of course, is thyroid function. And, of course, is very synergistic or required for the thyroid function. This is where I was talking about earlier that when a woman, either before pregnancy or during pregnancy, she develops anemia. And she talks about being fatigued, and she also talks about, I want my blood levels checked, and you see that her hemoglobin is down, you see that her MCV is low, and so she's a typical microcytic hypochromic anemic. First thing you can say, oh, you're female, here's iron. But yet a lot of people don't realize that B6 deficiency and zinc deficiency and copper deficiency and B2 deficiency can cause a microcytic hypochromic anemia. And so if you give her iron, and even if she's borderline iron, but she doesn't have enough zinc, she doesn't have enough B2 or copper or something like that, it's going to present the same way. And that's why there is no way you can just look at a CBC and say you need iron. And this is where when people talk about statistics, it's very misleading, where they say 90% of women that are anemic are iron deficient anemic. I truly feel that a lot of that is misdiagnosed, that they assume that they're iron deficient because they're having menstrual cycle and they're more prone to iron deficiency, of course, than men. But the point is, if you look at the average consumption of B6 and copper and some of the other nutrients that are like zinc that are associated with hemoglobin production, that we are not taking enough of those nutrients in our daily diet. And so those other nutrients are just as important and should be looked at with the female. So just don't take the simple CBC or even the iron profile that looks normal and yet the CBC is abnormal and still give her more iron. Now, when we talk about iron, of course, we talk about two types of iron. We talk about non-heme iron and heme iron. And of course, the heme iron has a much better absorption, and that's the one that we primarily find in animal products. The non-heme is primarily in, of course, plant products. The heme iron has about a 10 to 30% bioavailability. The non-heme has about 1 to 10% bioavailability. And so when people are talking about, oh, I get my iron from spinach, well, what people have to realize is that the iron in spinach doesn't have a very high bioavailability. Even though we may have analysis that it contains so many milligrams, there's a lot of interference. So the type of iron, where the iron is coming from, as far as food source, is very important. And that is also something that you must consider when you supplement or utilize iron in an individual. Let's talk about protein. Of course, one of the things we always want to look at is the protein a complete protein? Is it a partially incomplete protein, or is it a totally incomplete protein? As we know, in order for growth and development, we have to have complete protein. And you can see that, once again, there's discussion here about vegetable sources as well as animal sources. And it all depends upon not just this macronutrient, as it states here, but also about the micronutrients is once we get the protein in, once we get the amino acids in, are we able to assimilate those amino acids into other proteins of need? But this is just something to consider when we're looking at this and how we can change the protein content, and are we evaluating the protein content of an individual that may increase or decrease our chance of fertility. Fatty acids, once again, we mentioned that they have a part to play. Of course, one of the things that we know out there in the literature is in PCOS, we know that women have more difficulty getting pregnant. We know that there's a relationship of the insulin receptor, and we look at metformin and other medications to help this occur. Well, one of the things that, once again, is very important is the type of fat. We talk about, of course, cis fats and the trans fats, and you can see here that we have a consumption of certain types that may really be more of a detriment than others. And so I think this all goes back to the process of lipid peroxidation, is are we breaking down our lipids that may be causing free radicals, causing oxidative stress that are actually inhibiting this. On the other hand, are we consuming enough of the good fats to actually maintain the cell membranes to allow the hormones to work the way they're supposed to? So I think it's very important in that aspect that we keep that in mind. That, one, what kind of fat is the individual consuming, and are we going to increase the risk of some of these problems with too much of the bad fat versus the good fat? Now, when we talk about brain development, one of the first things, of course, that comes into play or people think about, and we see this in more and more companies that make nutritional supplements, is DHA. Is we know that DHA is very important for neurological development, and we've seen, you can see there's some research is showing the relationship with birth weight and head circumference and birth length, and that's all important, of course. And those are the major standards that when you know, if you've had at least one child, you bring your child to the pediatrician and they do three things. They measure the head, they weigh the child, and they measure the length. So those are markers, of course, are put into the pediatric chart and say, oh yeah, your child's growing at the perfect rate, they're developing, and so on. Well, that's not the only thing that affects, once again, the brain or these developments, the DHA. We know, you can see here that vitamin D is important. We can see, of course, that folic acid comes into play, of course, the iodine. And one thing that I think is very important that's often overlooked is zinc. And we're going to talk about that in a little bit. But the point is that some of the nutrients that are standard in your prenatal may actually be causing some problems with zinc. And this is another reason why we need to monitor these particular individuals from a standard of objective test, not just assuming that the individual is getting enough nutrients because they're taking a prenatal. Here's some statistics. You're probably all familiar with this. If you can see back in 1996 that there's a whole task force that recommended, of course, supplementation with folic acid to, of course, prevent the nerval tube defects. And this is something, of course, all of us fear in children, and of course the folic acid came into play. And once again, that's why I think also the MTHFR importance or research was done, and more people look into that with the female. But once again, we also know that folic acid can affect the male as well from a fertility standpoint, so it's not just the female that we're looking at. And once again, I'm going to talk about some relationships with folic acid and other nutrients. So here's, once again, showing you how folic acid may be associated with progesterone levels, and once again, how this is extremely important for not just neurological implications, but also hormonal balance or hormonal regulation. And of course, this is where dietary measures come into play. If an individual, avoids the fruits and the vegetables, they're going to have a better chance of having folic acid deficiencies. And we often see that, I think, more in males than we do females. On the other hand, certain nutrients like iron and zinc are more commonly consumed in men than females because of the food sources. Now, one of the things when we talk about folic acid, we also can tie that into homocysteine levels. And once again, homocysteine is looked at primarily from a cardiovascular standpoint or also a stroke standpoint. But yet homocysteine has been coming up more and more in the literature for other conditions. We see it with osteoporosis, we see it with dementia, we see it, during pregnancy and so on. So here's some research showing you how homocysteine concentrations may actually affect the female patients. And when we think about homocysteine, most people think about folic acid, B6, and B12, but it's larger than that. We have to look at B2, we have to look at serine, we have to look at choline, and those are some other things that are very important to keep in mind. So once again, ask yourself, can you look at an individual and say, oh yeah, I can tell that you're choline deficient, that's causing a homocysteine elevation? No, none of us can do that. I don't care how long we've been in practice, and so it's important that we do some objective testing. So here's some research on choline. Now once again, choline is one of them. Just like we talked about SNPs with folic acid or some other nutrients, you can see there's also some SNPs that have been associated with choline. Choline is very important for neurological development. It's very important for liver function. It's been shown to be beneficial for muscle spasms in the athlete. And you can see here now that there may be some relationship with the integrity of sperm. So once again, this is something that I think is very important to look into, and I think we're going to see this more and more when we look at other SNPs. And if someone is taking choline, why are they still choline on a nutrient test? It could be, once again, a genetic abnormality. Zinc, as you all know, is a major player in our health. Next to magnesium, it has the most enzymatic functions, or I should say biochemical functions, and there are a lot of things that come into play when we talk about zinc. Most people associate zinc with the immune system. Well, once again, I talked about this earlier, that iron deficiency can cause a microcytic hypochromic anemia. Well, also, zinc can do this. The other thing is, zinc deficiency can occur with high dosages of folic acid. Now, they have found in some studies that it only takes about 350 micrograms of folic acid to actually cause a zinc deficiency. And if you think about it, most of your prenatals have 800 micrograms or 1 milligram or 1,000 micrograms of folic acid. So if that's the case, you have the chance of actually causing a zinc deficiency. Now, from a male standpoint, once again, they may be taking a multivitamin supplement that has folic acid in it, and most of the times, even in a male multivitamin, there will be 400 micrograms. So that could do it as well. So there's a lot of things that come into play, and you can see here that at the very bottom bullet that there's been associations with zinc and prostate status and mammary gland status and diabetes and so on. So we know that zinc is very important, and we also know that zinc is an antioxidant and how it can play a role in oxidative stress. Here's a slide of several different functions, or I should say relationships of zinc with spermatogenesis, and also, of course, the relationship of Crohn's disease and other conditions that may predispose us to zinc deficiency. So once again, we know in some cases when women have Crohn's disease or ulcerative colitis, how getting pregnant actually has been shown to put some of these into remission. On the other hand, if they have a history of this, how it may indicate or predispose them to a zinc deficiency. So here we have a male individual in the mid-20s, should be adequate with testosterone, should have adequate spermatogenesis and all this, but because they're Crohn's disease, they predispose themselves to zinc deficiency, and they start to have these motility issues or production issues. But once again, as I mentioned from the very beginning, who comes into our office most often? It's the female. And yet you can see there's been a lot of literature here indicating the different nutrient deficiencies and how often this may be present in the male individual. Here's some other information as far as the zinc ligands and infertility, and also how we know that certain lifestyle conditions or certain medications may actually cause some zinc deficiency and other trace element deficiencies. As we know, meat sources, are, especially red meat, is the best source, best bioavailability form of zinc, where, once again, when we look at zinc in plant sources, that the bioavailability is very low. And look at what it says here at the very bottom, and I want to emphasize this. It shows here that the sources of zinc, but according to the World Health Organization, that they guesstimate that 1/3 of the world population is deficient in zinc. 1/3. And so if we're dealing with this, you can see how this may play a huge role with fertility. And this is why I think it's so important that we just don't assume that a person consumes a high amount of meat or animal products in their diet and they think that they're adequate in zinc, because there's so many other factors involved. So what about the overall development? We know, once again, that a child's head circumference, their weight, and their height has actually been associated with, once again, zinc status. We've seen that in women that have low zinc status actually deliver children with cognitive problems and also growth and development problems. From a male standpoint, you can see that, once again, the sperm integrity is changed, and we see that the function is also affected with this particular one. So it's not just production, it's motility, and in the female, we know that the child's development may be affected. We all know that another condition that can affect fertility is thyroid dysfunction, hypothyroidism. Once again, zinc is essential for thyroid function. It actually is important for thyroid receptor integrity, and if a female has a low zinc level, once again, she can have thyroid issues, which of course could also affect her fertility issues. When we look at tissue content of zinc and the effect on hormone production, you can see here that it definitely has been associated with testosterone production. It also has been associated with LH and FSH. So once again, when we talk about zinc, we're not just looking at the sperm motility, sperm development, and antioxidant function, but we now, from a female standpoint, are looking at the LH and the FSH. Once again, as I mentioned earlier, high consumption or consumption of folic acid over 350 micrograms can, it doesn't mean it's going to, but can affect zinc status. And this is where we can see some problems. So once again, hopefully this gives you an indication of why we need to test and why we need to look at various nutrients. And as you can probably see, and you probably say, well, where is the B12 information? Where's the folic acid? And as I was talking to the marketing people this evening about this particular topic, is this topic, there's so many nutrients involved that I think it's very likely that a second part will come into play with fertility and some of the other nutrients that maybe you're more familiar with. But I wanted to hit some nutrients that are less likely talked about or discussed with the patients when we talk about fertility issues.
Great. Thank you, Dr. Grabowski. That was a great presentation. We did get several good questions, so I'm going to jump right in. Several of the questions were very specifically relating to miscarriages, specifically about common deficiencies contributing to that, playing a factor in that, and then also touching on testing MTHFR and looking for possibilities of, miscarriages.
I think testing, once again, MTHFR is very important in that aspect. But once again, as I mentioned earlier, I think we're finding out, and researchers are discovering more SNPs or genetic abnormalities with other nutrients. And I think because folic acid has been such a hot topic and important role in pregnancy, that we've pushed so much research in that direction, but I think we're going to find that other things come into play. Of course, as we know, most miscarriages will occur in the first 12 to 16 weeks. And of course, the first 12 weeks are very instrumental for neurological development, and that's why I think that the nutrients that play a role with RNA, DNA, that really also come into play with the antioxidant function and oxidative stress are essential. And I think we're going to find this out more and more down the road, that addressing inflammation with pregnancy or infertility issues is going to be just as important as we look at inflammation in cardiovascular disease or diabetes or anything like that. So I think one of the things that we have to look at is the reproductive nutrients, like the ones that really address DNA and RNA, and addressing oxidative stress.
Great. And I know you touched on some of the higher risks or some of the higher considerations in infertility in age groups, especially when you're looking at the IVF. But in general, how do you look at the different age groups for both the male and the female that are looking to, get pregnant? Are there specific nutrients that you're looking at in specific age categories, or is it very generalized?
No, as we get older, one of the things, and when I say older, when we get into mid-30s or early 40s, one of the things that I see with females that comes up very often, now it's not found on a serum testing, but I see this on spectral cell testing, is B12 deficiency. The other thing that I often find with males and females, but probably more with females, is insulin resistance. And of course, we know there's a lot of research on PCOS and the relationship of PCOS and infertility, but there are certain nutrients that play a role with insulin resistance that have been documented in pregnancy/fertility literature. Magnesium, zinc, vitamin D, those are some common ones that we know affect insulin resistance. And I see that also in my practice very often. And yet, if we go and look at, those particular nutrients from a serum standing, we don't see that. But when we do something like intracellular with spectral cell, I see it much more often. The other thing is women that have been on oral contraceptives for a period of time, when I'm talking 2, 3, 4, 5 years, and they discontinue them, of course, and they try to get pregnant, is we often see B6 deficiency with them, and we see folic acid deficiency with them. And so I think it's very important, if a woman has been on an oral contraceptive for several years, that she definitely gets checked after being off them before she tries to get pregnant, and that she just doesn't go ahead and say, okay, I'm going to take a prenatal for a couple months and then hopefully try to get pregnant. Because those deficiencies, especially B6 and folic acid, are related to DNA and RNA synthesis. And we all know that those two products, those nuclear proteins, are essential for cell replication.
Great. Also, several questions regarding thyroid conditions. Obviously, a lot of women experience some thyroid problems after pregnancy. Some, even have problems before pregnancy. And what nutritional components do you look at in that relation?
Right. That's a great question, and I think that's something that I think is often overlooked. There was a study, if I'm not mistaken, it was published out of Italy a few years ago, showing that 30% of women that develop postpartum hypothyroidism actually have selenium deficiency. And so as I mentioned earlier in the lecture, that selenium is a major role with, of course, oxidative stress. We also talked about T4 conversion to T3, that selenium plays a role there. Zinc, as I mentioned, once again comes into play because women are taking a prenatal with folic acid, can cause a zinc deficiency, and zinc, of course, activates the thyroid receptor. So, women get through their pregnancy, of course, they start taking care of the child. They go to the OBGYN or the pediatrician. They say, I'm exhausted. They go, of course you're exhausted. You just had a child. Well, the question is, where is their thyroid markers? What's the TSH? What's the T4, the T3, the T3 uptake, all of those, not just the TSH, but we have to look at the full thyroid panel. And then relate that, or they may still be microcytic hypochromic anemic, and they say, okay, well, you're deficient in iron still. We need to pump you with iron, and yet they're not deficient in iron. They may be deficient in zinc. And as I mentioned from that one slide, a third of the people in the world have been shown to have an insufficient amount of zinc, and zinc is primarily, once again, it's best absorbed from meat products. So if a woman now, she's pregnant, or I should say she's done with her pregnancy, she wants to start losing some of that weight that she gained during the pregnancy, she goes more towards the fruits and the vegetables, she stays away from the protein products or the high-fat products that also contain zinc, and next thing you know, she becomes hypothyroid or she has thyroid dysfunction. So I think it's very important that we keep those two nutrients specifically in mind when we look at thyroid function throughout the entire pregnancy, not just postpartum.
Okay, great. Well, I think that closes up the questions and the webinar for this evening. Thank you once again. Just to close out, to let everyone know that this will be posted on our website, and we will be sending a link to the recording for this webinar presentation. And please don't forget to join us next month for our webinar series. Thank you once again, Dr. Grabowski, and good evening, everyone.